Good evening, everyone. Please welcome to the stage Jennifer Bernard.
Good evening, everyone. Hello. Please take your seats. We have quite an evening planned for you. Take a look around. We're making history. It's a moment. Take a picture. You are part of history. All right, we've got lots to cover tonight. I want to thank all the folks that dinged me on social media to say they were coming, they wanted to come. I so appreciate the support. For those of you who I've not had the privilege of meeting and I've not met yet, I hope to meet everybody in the room. My name is Jennifer Bernard, and I am the extraordinarily proud President and CEO of Women's College Hospital Foundation. When I got this role in 2018, anybody that knows Share magazine, can I have a shout out for Share? Right? The editor, Ron, said, "You're the first Black CEO in healthcare." And I said, "Don't print that." I don't know that that's true. I found out later it was. And so this evening is the culmination of so many dreams, personal and for our community. Since then, there are other Black CEOs, both in London and here in Toronto, and I'm so glad not to be the first and the last. So, like everybody in this room, I have many, many intersectionalities. I am a Black woman, I am an immigrant, I am a mother, I am a partner, I am a friend, and I am a colleague. And I'm a very proud Canadian. And so we start with a land acknowledgement. I ask that we all take a moment to collectively acknowledge the lands upon which we gather as the ancestral lands of the Huron-Wendat, the Anishinaabe, the nations of the Haudenosaunee Confederacy, and the Mississaugas of the Credit First Nation. We are grateful for the opportunity to live and work on these lands, and it's wonderful to be here with you. We have been planning this event since 2020 when we had our online summit in the midst of COVID. We got such a wonderful response that we knew we had to bring it back. And this is one of our first in-person events since the pandemic, so welcome. So I really can't think of another hospital in Canada that could assemble the truly exceptional lineup of speakers and the opportunity for us to be in community other than Women's College Hospital. It was founded over 140 years ago by Dr. Emily Stowe to advance equity for women. And we today take that mission just as seriously because we know when we say women, we want to mean all women, women everywhere. It's not performative, and it's embedded in everything we do. In 2019, I had the pleasure of being at a conference with the president of Ethiopia, the first female president in Africa. She ended her speech with an African proverb that goes like this: "If you think you're too small to make a difference, you've clearly never spent a night in a room with a mosquito." Tonight, we are all mosquitoes, and together, we are going to change the world. Over the next few hours, we will deliver what promises to be an educational and informative and thought-provoking event focused on Black women's health, something that is long overdue and rarely done. Now, I'm going to tell you in advance, we will not be able to cover everything in the next 2 hours because there is so much to cover. I have never had so much advice as to what we should include. We have included so much, and we know there's so much more to do, and this is just our first step. We will come into community. We will go to where the people need us more, but we had to start here today. We know that everything we do stems from the inequities and the systemic racism that are created from the power imbalances in our society and in our healthcare system. The harm that is done to the Black community and those that work in healthcare, the providers, the physicians, the researchers, all that harm is real. Just this morning, there was an article in the Toronto Star which Canada's premier medical journals acknowledged their role perpetuating anti-Black racism in healthcare. Thank you, Rosemary Davis, for sending that article to me. Tonight, we will be tipping the scale in your favor, arming you with the life-saving information and tools to advocate for yourself, or to be an ally, to raise all our voices in support of healthcare equity. Our foundation has assembled a truly exceptional lineup of moderators and panelists. Our speakers are all experts and leaders at Women's College Hospital, and it's amazing that we did not have to go outside of our hospital to find these people. They are all Black or racialized, have lived experience, and live in our community. And these racialized leaders are authentically embedded in this work. We will be taking a deep dive into the challenges and the necessary conversations around the health of Black women. But make no mistake, it's not just about the health of the Black community and Black women. It's truly about everyone in this room. Each of us plays a vital role as advocates and allies and champions for Black women in our lives and in our communities. This is part of our collective effort towards creating an equitable healthcare system where none of us is left behind and all of us feel we belong. To create an event like this, it takes a village. I wanted to thank my board of directors, who is represented tonight by Debbie Simpson. And Debbie, I think, brought everybody from Havergale that she could, and also was a champion for this. We embedded this event in our strategic plan. This is not fluff on top. This is part of our strategy and our promise. This historic event would not be possible without the support of new and longtime sponsors, and a special thank you to our presenting equity sponsor, Scotiabank and MD Financial Management. Thanks also to our advocacy sponsor, and our first sponsor actually, Canada Life. Joining them is TD, and our community sponsor, Life Labs, and our action sponsor and longtime supporter, KPMG. One final round. So what will happen over the next few hours? We hope you will leave this event not just informed, but enlightened, energized, and ready to mobilize. Take action in your own lives and within our community. I also hope that the fear and the mistrust is slightly eased, that you feel that there is a place that is rooting for you, fighting for you, where you belong. We hope to provide you with the tools to develop your own personalized prescription for advocacy and help, and we hope you continue these conversations long after you leave here tonight. So you know what we're talking about, social media. Post your pictures, post your conversation, post your questions, post those lightning moments that come to you. Use the hashtag BWHS2022. We're also delighted to have in the house Emily Stowe's Scholarship Fellows celebrating their reception and their first time being celebrated. And that's going to take place at the end of the evening. I hope you'll stay for that. And now, I'm delighted to introduce Heather McPherson, who's the president and CEO of Women's College Hospital, and she is a true ally both inside and outside of our hospital. Thank you for coming.
Good evening, everyone, and I'm honored to join you tonight for these critical conversations. At Women's College Hospital, we have a vision to revolutionize healthcare for a healthier and more equitable world, where everyone has access to safe, compassionate, and culturally competent care. We also appreciate that hospitals and healthcare organizations are viewed by many as unsafe spaces, due to historical and present-day discrimination and harms. I believe this work begins from within, and at Women's, we're on a critical path to dismantle racism and oppression at every single level of our organization. We are taking action to address and center the distinct healthcare needs of Black women and to ensure that our hospital is a safe and compelling space for Black women to access care. The goals of our efforts are to improve care experiences for Black patients, caregivers, and visitors, as well as Black staff, physicians, and volunteers. We know, and the research tells us, that representation matters, that having someone who looks like you or shares a common experience caring for you can help you feel safer, feel seen, and feel valued. And that leads to better care and to better outcomes. We are actively working to increase greater representation of Black staff, physicians, scientists, learners, and volunteers across all levels of our organization. Today, our board of directors at Women's includes 60% racialized elected members with 5 Black directors, and 45% of our senior leadership team at Women's are racialized leaders. And through the Emily Stowe Foundation, we are building a pipeline of Black healthcare and health science leaders. We are starting this work from within. Racism continues to exacerbate long-standing inequities in health outcomes in Black communities in Canada. We know that Black women are disproportionately affected by chronic disease and experience increasing mortality rates for numerous health conditions. And we don't fully understand it because there is a lack of Canadian race-based healthcare data and research, making it difficult to address the health disparities experienced by Black communities and leading to the erasure of their unique experiences. As part of our ongoing work, we are committed to increasing race-based data collection for the purpose of studying the impacts of racism, specifically anti-Black racism, on health outcomes and access to care. We recognize and value partnerships with the Black communities and organizations that serve them. At Women's, this means building meaningful community partnerships to support work that considers the unique experience of Black women. Later this week, we are partnering with Women's Health and Women's Hands, Taibu Community Center, and the Olive Branch of Hope to facilitate a breast and cervical cancer screening event specifically for Black women, who often experience stigma and mistrust in the health system, leading to lower screening rates. And this is just the beginning. As long as anti-Black racism and systems of oppression continue to exist, we must do the ongoing work to dismantle these systems, to close health gaps, to advocate for better care and research. And this journey is not close to over. We are committed to and undertaking the work to achieve a healthcare environment that is free from oppression and racism. I'm deeply honored to work alongside the Black community to dismantle anti-Black racism at our hospital and beyond. Thank you very much.
Please welcome from our presenting sponsor, Bridget Paton.
Hi, good evening. My name's Bridget Paton, and I'm a senior financial consultant with MD Financial Management. I'm so honored to be here with you this evening on behalf of both MD Financial Management and Scotiabank Healthcare Plus. At both MD Management and Scotiabank, we help our physician clients and their families throughout every life stage and every stage of their careers as well. So right from the first day of medical school to practicing in their fields, and then through retirement as well. So with that, they can focus on their families and whatever matters to them most. So after 19 years now at MD Management, I couldn't be more proud and more engaged about what we do. We strive to create a culture where every employee is empowered to reach their fullest potential and that they're respected for who they are. A culture where our differences and our similarities are both embraced. But we can't do this alone. we're only as strong as the communities that we serve. And by working together, all of us, to remove barriers to improvement and to create access to opportunities, we can all create a more resilient and inclusive world for everybody. So, as of this last January, Scotiabank actually celebrated the first anniversary of Scotia Rise, a program where we've committed $500 million in funding over 10 years to promote economic access to disadvantaged communities and cultures and women. Thank you, yes. Thank you. Yes, we understand the importance of uniting communities in support of women's health and in health equity for all. And in 2021, Scotiabank also announced a 5-year gift to Women's College Hospital to support the Women's Virtual Program and Compassionate Fund for the Crossroads Refugee Clinic. Now, this one is to give every woman every chance at healthcare that she needs and that she deserves. Thank you. Yes. But our work to build a more inclusive society is never done. We will build on our successes and we'll learn from our failures. And tonight, I want to thank each and every one of you for being here today at the Black Women's Healthcare Summit. We're here to learn and we're here to shape the future for equitable access to healthcare to make sure that it's a reality for everyone. And now, I am delighted to introduce our moderator and our panelists for the first session. The first session is Prevention and Living Longer, Black Women and Cancer. The moderator for this discussion will be Dr. Aisha Lofters. Dr. Lofters is the Chair of Implementation Science at the Peter Gilgan Center for Women's Cancer at Women's College Hospital. She's also the Provincial Primary Care Lead for Cancer Care Ontario's screening portfolio. And Dr. Lofters will be joined by 2 esteemed panelists. The first one, Elaine Goulbourne, is a clinical director and primary care at the administrative director for the Peter Gilgan Center for Women's Cancers at Women's College Hospital. And she has over 26 years of leadership, administrative, strategic planning, and partnership development in healthcare, as well as cancer care, women, and children's health. Wow. Our next panelist, Dawn Barker-Pierre, is a patient advocate and ambassador for the Olive Branch of Hope Cancer Support Services. The Olive Branch of Hope provides support and education for our diverse community and helps identify and remove barriers that prevent individuals, particularly those from African ancestry, from accessing the available health care that they need. Please join me now in welcoming this incredible panelist to the stage.
Good evening, everyone. Thank you so much for joining us. It is great to see this sea of faces here today in person. What we're here today to talk to you about is Black women and breast cancer specifically. Now, we know that for many people, when they have a particular concern, they find something in their body or they're worried about their health, that they feel very safe and comfortable going directly to their doctor. But that's not true for everybody. And we know that for Black women in particular, there often can be mistrust, there can be misconceptions when speaking to your doctor, and we face often these systemic barriers. So what we want to do is talk about that here today. So the very first question I want to ask of our panelists is towards Dawn. Dawn, you have a very powerful story, and wondering if you could share that with our audience here today.
Thank you very much. So before I start into my story, I just want to engage the crowd a little bit, and I ask everyone in the room if they've been in fact impacted by cancer in any way or form, not yourself or your family member or friend, just by a show of hands. Wow. Wow. That's pretty much everyone in the room. Thank you for doing that. The importance of advocacy started with my parents. as you can see on the screen, this is my mom and my dad. They both passed away from cancer. My mother in 2015 and my father in 2019. And my advocacy started with them because there were a lot of things that were going on in the hospitals that we needed as a family to be there to advocate on their behalf. So this is actually where my advocacy interest began, with these two individuals here on the screen. My mother, she taught me to care for individuals, to take time with people, no matter their color or their cultural background. My father, I think I got my sense of humor from him, but other than that, he taught me to be bold and to speak up for what I believe in. Now, this is little Dawn. Little me at the age of 3 in Barbados, where both my parents were born. I was born there as well. And this is innocent little Dawn, not knowing what's going on. You know, we lived in Barbados, which is a very warm climate, and we had a lot of family, surrounded by family and friends. And community is a big part of my upbringing. In the West Indies, your neighbor is your best friend. Your neighbor knows what's going on. Your neighbor protects you. Your neighbor looks out for you. So that's the way I was raised. I had my whole life ahead of me, not knowing anything, you know, just innocent. And as I get older, 40 to be exact, I started thinking ahead, thinking, what should I do to protect myself? So at the age of 40, I went to my family doctor and I asked him if I can have a mammogram, trying to be proactive as opposed to reactive. And I was told no. Again, at 42, I asked, can I have a mammogram? Can I start having mammograms? And I was told no, not until I'm 50 years old. That speaks ageism to me. 50 may be the mark, but 50 is not the mark for everyone. Not every shoe fits. So that is what I encountered at the age of 40 and 42. Little did I know what was ahead of me. In March 2017, I discovered changes with my appearance, in my face, and they started darkening. My eyes actually started darkening. And it will show on the picture where my eyes began to darken. And I thought this was odd for me. This was something that I've never witnessed before, and it happened almost in an instant. So I went to my doctor and I asked, what's going on? And I was sent out the door and dismissed as age spots, dark spots. Well, I went home and it didn't sit well with me. And I thought, something is off, something's going on. So I went to another doctor. I was referred to a dermatologist now. The dermatologist told me, yeah, it's just age spots. There's nothing to worry about. There's nothing you can do about it. It's just, you know, simply with aging that happens. I left that office, and again, in my gut, something just wasn't right. So again, I went back to my family doctor and I said, something's going on, can I please get some blood work? And he looked at me like, you want blood work for, you know, the dark spots? So I said, you know what, just humor me, can I have some blood work, please? So I went, I had some blood work, and that was when it was revealed that I had an underactive thyroid. And I started on some medication for that. Well, about 2 months later, I found a lump above my left breast. I rushed myself to the walk-in clinic, and they did biopsies and scans, and ultimately it resulted in early stage triple-negative breast cancer. I have never heard of triple-negative in my life before. That was the first time. So, pictured in the screen is me, the first picture with my hair is when I began to actually, it shed after the second dose of chemotherapy. That was devastating for me. As a Black woman, our hair is our crown. Our hair is our identity, you know, and losing it, you can see the bald picture of me there. I was not happy. I didn't like who I was seeing in the mirror. Now, after surgery, I had chemotherapy, and after chemotherapy, I had radiation. The chemotherapy actually was 7 out of 8 rounds I had. I did not go through with the full 8 because I developed neuropathy to a very large extent. So my doctor and I advocated for myself in that regard as well, and I said, you know what, I don't like what I'm feeling. I think we need to reassess the 8th dose. So he agreed, and we stopped at the 7th dose. Now, after receiving my second round of chemotherapy, I had the hair loss, as I said, and following that, I had radiation. I had 25 rounds of radiation, and really and truly, where it struck me that I had cancer was when my hair started to fall out in my hands. Before that, I guess I tried to deny it. I tried not to believe that it was happening to me. But once I started to lose my hair and it was in my hands, that's when reality struck for me. So this is me. This is me pictured here, now, present. I can actually say that I am a triple-negative breast cancer survivor. Thank you, thank you, thank you. Thankfully, I lived through it, but not many people do. So I count myself as fortunate, I count myself as blessed, and I can honestly say that it's my faith that helped me through what I went through. And a lot of women and men and families from the West Indies lean on that faith for difficulties. So faith was a huge thing for me going through my battle with breast cancer. My goal is to be a person who can advocate for women with breast cancer. My goal is to be the person that I wish I had when I was going through my treatment. Now, I'm going to show my why on the screen in a moment. These 3 are my why. This is my son Thomas, my daughter Jacqueline, who's here tonight, and my sister's also here, and my son Jaden. Well, he's older now, he's actually 16, but this is the most recent picture I have of them because my oldest son moved away to the UK. So this is my memory of them all 3, smiling, happy, laughing. And these 3 are my why and why I'm here tonight and why I do what I do. I want to leave a legacy for them. I want to show them that your voice matters. What you have to say matters. We all have a story to tell, and we need to tell it. We need to use our voices, because otherwise no one will know what you're going through, and no one can help you if they don't know. I want to take a quick second just to read something to you, and I hope I'm going to be really on time here, but this poem was read by our first poet laureate, actually, Randall Ajay, and when I heard this poem, it stuck with me. It says, I read of a man who stood to speak at a funeral of a friend. He referred to the dates on the tombstone from beginning to the end. He noted that first came the date of birth and spoke of the following dates with tears. But he said what mattered most of all was the dash between those years. For the dash represents all the time they spent alive on earth, and now only those who love them know what that little line is worth. For it matters not how much we own, the cars, the house, the cash. What matters is how we live and love and how we spend our dash. So think about this long and hard. Are there things you'd like to change? For you never know how much time is left that can still be rearranged. To be less quick to anger and show appreciation more, and love the people in our lives like we've never loved before. If we treat each other with respect and more often wear a smile, remembering that this special dash might only last a little while. So when your eulogy is being read, with your life actions to rehash, would you be proud of the things you say about how you lived your dash? Thank you.
Thank you so much, Dawn, for sharing your stories. I think it takes a lot to come up here and be so open and vulnerable, and we really, really appreciate that.
Thank you.
And I think, you know, your story really covers so many of the issues that we're going to be diving into. So, Elaine, I'm going to turn to you for the next question. So we know that in the U.S., Black women are actually 41% more likely to die of breast cancer than white women. Now, in Canada, we don't know what those statistics are because we don't collect race-based data. We'll come back to that. But we know that there are disparities here. So, Elaine, what do you think it is that's leading to those disparities in our context?
Thank you, Aisha. But first, I want to thank Dawn for sharing her story. And Dawn, thank you for your courage.
Thank you.
Thanks, Aisha. We know that Black women are more likely to die from breast cancer than white women. There are many factors that are contributing to this. Black women are more likely to be diagnosed with more aggressive forms of cancer at a younger age. And we hear that in Dawn's story as well. And research has showed us that Black women are more likely to receive a late-stage diagnosis due to delayed screening. What this means is that they're diagnosed late, they're diagnosed at an earlier age, but with a more aggressive form of cancer. And in Ontario, the Ontario Breast Screening Program recommends screening for breast cancer for women at age 50. And the stats that I'd like to share with you is that 23% of Black women who are diagnosed with breast cancer are diagnosed before age 50. So we have to take a look at that as well. And there are increased incidents that demonstrated that Black women are more likely to carry the BRCA1 and BRCA2 gene mutation. Individuals who carry this gene mutation are at higher risk for developing breast cancer. So there are multiple factors here. So in summary, Black women are more likely to die from breast cancer because they're diagnosed with a more aggressive form of cancer at an earlier age. They're diagnosed late, at a late stage. Also delayed screening because of the recommended guideline for at 50. And as I shared with you, we're diagnosed before age 50. So how do we access screening before 50? And also because of the higher risk for being carriers of BRCA1 and BRCA2.
Thank you so much, Elaine. So you touched in your answer on the topic of screening, and I want to talk a little bit more about that. So, Dawn, you talked about wanting to be screened, but we also know that there are barriers for women, for Black women specifically, to be screened. What thoughts do you both have about what those barriers are when it comes to breast cancer screening?
For myself, I think it comes down to education. And I think it should actually start early. I think it should be done in the schools. I think it should be done in the health classes that they teach in schools to screen. For Black women specifically, to screen early. Like I said, I was diagnosed at the age of 44. That's under 50. So this 50 mark is not the thing. It's not the be-all and do-all for everyone. So I think we need to eliminate this 50 mark and the fear of screening as well. I think a lot of Black women have a fear of the screening. What I've been told as well from the women that I speak to is the pain. They don't want to experience the pain from the actual mammogram. And as well, there's a misconception that they can develop cancer from the mammogram, for the radiation that comes from the mammogram.
Thank you, but I've heard those same concerns myself.
Yeah.
Elaine, anything you wanted to add about screening?
Absolutely. I think there are multiple factors in terms of barriers. I want to touch on access and barriers themselves, as well as education and awareness. But I just want to start by saying that as a culture, we're afraid of the big C meaning cancer, and the results of that in terms of death. But the conversation here tonight is around prevention, early access, which save lives. So if there's one message I do want you to walk away with is screening, early detection, early treatment, early diagnosis save lives. And in terms of access, I often hear that there's a lack of awareness around how to access screening before 50, availability of appointments after hours and weekends when women are not working and busy working, barriers such as transportation, access to daycares for single mothers who cannot make it to the appointments and don't have daycare access, lack of medical coverage such as HOHIP, and of course navigating the healthcare system. And these last two are true for new immigrants to Canada and how to access the system. And mistrust, which we'll talk about later in terms of with the system itself. Dawn touched on education and awareness in terms of lack of information that are tailored from a cultural perspective, that are tailored to Black women. So really, a way forward is for us to eliminate some of these barriers by making transportation available, daycare access, appointments after hours and on weekend, and really look at how we provide guidelines to support the uninsured for them to have access and moving that piece forward. So I think we'll pause there.
Thank you. All excellent points. Something else that I wanted to touch on, and even thinking, Dawn, in your story, you talked about family and your parents, so is the topic of family history. So we do know that, Dawn, as you mentioned with the triple-negative breast cancer, that women who are of West African ancestry are more likely to get triple-negative breast cancer. There's an amazing researcher at McMaster, Dr. Juliette Daniel, who's studied so much around triple-negative breast cancer and found a gene called Kaizo, actually, which she's named after Calypso, which has West African roots, which seems to be expressed more in women of West African ancestry. So I think first it shows the importance of research in our community, but it also raises the topic of family history. So Elaine, I'm going to ask you this question. What do you want to share with our audience and people more broadly about the importance of knowing your family history?
It is so important to have the conversation, Aisha. And as I mentioned before, we as Black women are predispositioned to carriers of the BRCA1 and 2 gene, mutation gene. Knowing your family history, not only on your mother's side, but also on your father's side is very important. Any history of cancer, what that means is that it will inform you of your disposition for cancers, whether or not you're at high risk for cancer. If the conversation comes up and there's history of cancer within the family, there's access to genetic testing. And genetic testing doesn't mean that it has to be invasive. It could be as simple as a spit test or a saliva test that you can do in the comfort of your home. And what that means, at Women's College Hospital, there's a project called the Screen Project. You can go online and look for it and get tested that way. And by being more informed about your family history, as I said before, you are available to have the conversation with your physician around your family history. You can access genetic testing, and what that means is early detection, screening, access to screening before 50, and making sure that we change the narrative, and the narrative is around saving lives, and making sure that we're looking at that as well. And I just want to share a story with you. My dad is an avid baseball fan, and growing up, when my dad is watching baseball, no one interrupts him, especially if, the Blue Jays are playing. And I perched myself down on the sofa beside him, and I said, Daddy, I call him Daddy, tell me about a history of cancer in the family. And he gave me this typical West Indian man look and said, really? You've got 10 minutes. But he gave me the information I was looking for, and I promptly shared the relevant information with my sisters because they needed to know. And I had the conversation with my family doctor. But I do encourage all women, everyone here, whether you're women or male, have the conversation, start the conversation around your family history because, as I said before, early detection, early screening save lives, and we don't have to fear the word cancer anymore and the outcome. It's having those conversations that is important.
Thank you. And I can say as a family doctor, it is so important when patients share their family history with us because then we know what extra steps and what earlier steps that we need to take. So we've talked a little bit about statistics and numbers, which often we end up pulling from the US because we don't have race-based data here in Canada. I think that there's a movement to change that. But Dawn and Elaine, what do you both see as the barriers to the collection and use of race-based data? And Dawn, we can start with you.
First and foremost, I think that recognizing that Black women experience cancer differently. We experience cancer differently, so that is the first step. And then the how and the why should be a priority to find out. So that's the first step. I also want to hone in on the aspect of finding out why there are no studies about mortality among Black women and the breast cancers and the types of cancers that we get, and we're more prone to being diagnosed with. The next thing is I think that there should be an analyzation of the tissue that's actually taken, the tumor. Take that, look at it from Black women specifically to find out what's behind this and why are we more susceptible. The last thing is as well, why are we relying on US data? Why are we? That's the question. Why don't we have our own? So I actually recently heard a study that came out on CNN in regards to hair straightening products that are geared towards Black women, that we are at risk of developing cervical and breast cancer from these hair straightening products that are targeted to us. And this needs to, there's a question as to why. Why? Why are we targeted with these products when they're harmful? So we need to look at that. And I was guilty of that. I used hair straightening products when I was growing up because that was the thing. We were shown these pictures of what beautiful and luxurious looks like, and we had, you know, the flowing hair, and we wanted that. So we bought into it, and we're now finding out, studies are showing that these things are harmful for us. So I made a conscious decision about 10 to 12 years ago to stop using these hair products and go natural. And that was the best decision that I've ever made for myself.
Thank you so much, Dawn.
Thank you, Dawn. Natural is beautiful. And from a statistical perspective, I just want to share with you that did you know that 51.6% of Canada's Black population is women? 51.6% of Canada's Black population is women. And half of Canada's Black population are immigrants. We are immigrants to the country, and that's including myself. A barrier to accessing race-based data is understanding the importance and the why. Why are data being collected and for what purpose? And data can be collected as simple as your country of birth, nationality, your place where you live, etc., and that's just data in itself. When it comes to research, there are different contexts and different types of research, and those need to be explained in terms of the impact. And why that is important is because, as Dawn said, it will inform us about Canadian data around Black women, Black men, about the data that affect us. What that will do is actually inform care, it will inform treatment, and also from a broader system and policy level, it will actually inform those guidelines. And so that when treatment and care are being developed, it's tailored towards us and specifically towards us. There's another context that I would like to share as well, is that historically, we hear about the term, I don't want to be used as guinea pig. How many have heard that term? Exactly. So it's wanting to make sure that term is out there where the Bloc population have had negative experience with being giving treatment and giving research and drugs, etc., without consent or full disclosure. And then that context about not being wanted to use as guinea pig is there. So we have to incorporate that information into the why and the importance. And once that full disclosure is given, then we're free to make those decisions. But those decisions are important for us in this generation, but if not for us or future generation, to inform the care that they will receive.
Thank you so much, Elaine. And on the slide, you can see here some work from an earlier study where we, along with some colleagues at University of Toronto, we actually looked at research and found just how little there is in the Canadian context. So it is such an important issue. Now, the three of us have been working together for quite a while now with bringing together the Peter Gilgan Center at Women's College Hospital and the Olive Branch of Hope organization. And one of the outputs that we've worked on is the Every Breast Counts resource hub. So Dawn, could you speak to us a little bit just about what that process was in the Every Breast Counts resource hub?
Wonderful experience. Thank you both for everything. Thank you, Aisha, for your vision for this project. I'm humbled to have been a part of it. There are three other women who we worked diligently to put this web page together. I call this a survivor's survival guide because that's what it is. I'm getting a lot of feedback from women that I speak to on this resource hub. It contains information that we sit there and ponder on, that we wonder, that we are afraid to ask. It's all there for Black women to access because we had no other place to go before. This hub is a place for us to resort to at 3 in the morning when we have questions to ask. This hub is a place to go to know that we are being represented as we should be, as we should have been many, many, many moons ago. As well, it's for Black women, by Black women. How better can it get? So I'm just so excited. It is. Thank you. I feel that Canada's failing us, you know, and this web page, this web hub is a be-all, not a do-all, but a be-all for what we are looking for. There's still some things to add, I believe, but I think we've got quite a bit here that women can hone in on and feel like they're being seen, heard, and represented the way they should be.
Great. Thank you, Dawn. It's been an amazing experience for us as well, and a great learning experience too. I will say I'm about to ask the last question, so I just want to let you know that after this question, we are going to welcoming questions from the floor. We have about 5 to 10 minutes after that for questions. So there are microphones, I think, on both sides. So if people want to start, if they have questions in mind, feel free to start slowly making your way up to those microphones for the questions. So Elaine, I'm going to ask you our last formal question. So, you know, Dawn talked about that experience working with us on the Every Breast Counts resource hub. Can you speak a little bit more about what's to come and the partnerships in Women's College Hospital and what we're doing going forward to support Black women in the world of breast cancer?
Okay, thank you. The journey didn't just stop with the website that Dawn spoke about. We had an event this past February during Black History Month, and we labeled it the Breast Health for Black Women. So we took the content from the online resources and bring it to a free online forum, and we partnered with Rethink Breast Cancer, Olive Branch of Hope, and Canadian Cancer Society to host this event. And I'm pleased to share with you over 400 women attended this event. And 93% felt that the information was, the place was a safe place to learn, a safe place to ask questions, and it was great to see that representation. 87% felt that they were, they felt seen, heard, and understood for the first time. So these are the work that we're doing, and I'm pleased to share with you, we're even taking it one step further. This coming Thursday, we're hosting an in-person breast and cancer screening event tailored for Black women at Women's College Hospital. We had a target for 30 mammos and 30 pops, and I have to tell you that we had to close the registration down early because we surpassed the target. So it demonstrates that there's a need out there for tailored information, culturally appropriate care in a safe environment. So there will be more to come and more events like this and how we tailored the work so that we continue to save lives. At Women's College Hospital, you see on the screen not only that we provide care, we provide care throughout the entire cancer journey, whether it's from prevention to screening to diagnosis to care and treatment and even aftercare. And there's a list, I won't go through it because of time. Those are the programs that we do have at Women's College Hospital that I wanted to share with you, that we do provide care throughout the cancer journey. Thank you.
Great. Thank you so much, Elaine, and thank you, Dawn. Any questions from the audience? I see we have a brave soul over here.
Hi, thank you so much. Try not to get emotional. But the reason why I'm here is because I'm very frustrated. I've had my doctor, moved to Toronto for 16 years, and I've had health issues that I feel he's been ignoring. Even recently, I miscarried, and he didn't even know anything about me, even in terms of my blood type. And I'm frustrated because there's issues going on with my breast, my body, and I have a doctor who doesn't really know me. And I'm hearing about, you're saying about advocating, and how do I find another doctor? I don't know, do I walk up to a doctor and say, can you help me? Like, I don't know how to advocate. It's not easy to call, a lot of doctors are not accepting people. So I'm stuck with a doctor who doesn't know me, doesn't know my blood type, and doesn't take my concerns seriously.
And I think that's unfortunately a common concern that I hear and that I think we all hear when it comes to finding a provider. I think in healthcare you have the right to have your questions answered, to have things explained to you, to have a provider, whether that's a doctor or nurse practitioner, who will, if they don't want to order, test it down with you and explain why. And our current system, you hear in the news all the time that we are in a crisis and that there are so few doctors who are taking new patients. Some of the community health centers that are dispersed throughout the city do take on new clients, is a term that they use. They do take on new clients, and there are a few community health centers that are actually have a mandate to focus on the Black community. So happy to chat with you during the networking event to see if we could share some resources as well with regards to finding a primary care provider. But it's not an easy situation right now.
Thank you.
I'll go to Tessa. Hello. Hi. How are you?
Good. How are you?
Good. Good to see you.
Okay, so I have a question. We heard about the 50 ageism when it relates to having mammogram. I'm wondering, is that number a hard stop number at Women's College, or do you guys overlook that for women younger than 50? And part two of my question is, as a group of women sitting here, how do we go about what is your recommendation about how do we go about changing that number to 40, to whenever a woman feel like they need to have that mammogram and not having to wait till they either feel a lump or they turn 50?
Great question. So one thing I think it's really important that a lot of family doctors don't know. So the way what the Ontario guidelines say is that at age 50 you don't need a referral. For people at average risk, at 50 seems to be an appropriate age to start, but you can have a mammogram if you are under 50. Between the ages of 40 to 49, what the recommendations actually are is that you have a conversation with your physician or your primary care provider about the risks and the benefits, and that if you would like to proceed with a mammogram, you should be able to get one. So a lot of providers think, no, it's just 50, yes, or it's just 50 and that's it, but that's not the case. The guidelines actually do state between 40 and 49, you just need a referral. So that might mean sometimes doing a bit of education for your physician to let them know that that's what the guidelines say, and I think that comes back to that topic of advocacy. But there's nothing in Ontario saying that you cannot have a mammogram starting at 40.
And to answer your question, at Women's College Hospital, yes, we do mammo for individuals who are under 40, ultrasounds if necessary as well.
Hi, I just want to say thank you for putting this together, and I'm just honored to be here today. But I wanted to speak to the fact that it seems like a common issue is that we don't know how we can advocate for ourselves. We don't really know what our norms are. And I also think that what can speak to that to help inform and change our practice is to have that race-based research. So my question is, where are we in terms of the race-based research in Canada? So it can help inform our practice. It can help inform our patients as to what we can do as racialized Black women, where we're at in our healthcare, what we can do for ourselves and what we can do for our patients. Like, where are we in that regards?
Yeah, so there has been a huge movement, I would say, within the last couple of years to start collecting that data. It's still a while away, but there certainly are various hospitals, institutions, clinics that are starting to collect that data themselves. At Women's College Hospital, we have a task force that's working on collecting race-based data as well as other data from patients and from staff as well. And at the provincial level, they are starting to talk about the collection of race-based data, because ultimately we need it to happen not just at one hospital or one clinic, but across the country, really, not just the province, so that we are able to use the stats just like we do from the US, right? And I totally agree. I think that that's the key, is we need the numbers. So there is a movement afoot, but I think the more voices there are that are calling for it, from clinicians, researchers, and the general public, the faster that those changes can happen.
Go ahead.
Hey, love. I'm so happy to see you here.
You can go first. I think you can go ahead.
Oh, you want me to go first?
Okay.
Okay, so look, I was gonna say the whole age thing is a bit confusing to me because my sister, and she's alive and well and a survivor of triple-negative breast cancer. So for those of you that don't know what that cancer is, it just doesn't respond to any hormonal therapy. So it's like one of the worst kinds of breast cancers, as I understand it. But I was gonna say the doctor for us said, look, 10 years before your sister was diagnosed is when you should get tested. And so I think the challenge that I'm having with the way that our healthcare system is sort of functioning is because when my sister had her lump and she went to a family doctor to get checked and she knew something was wrong because there's been cancer in my family, they said, look, we think it's a cyst, and come back. And then she came back. They said, well, we need to go do a biopsy, which then we started to freak out, right? And Black people, we all know how we get when crisis hits. Everyone calls everyone and says to my sister, well, you should go to Dubai, which is where my mom lives, and gets her biopsy done. Gets her biopsy done, gets more testing, gets a doctor, gets diagnosed, and then gets a call to schedule her chemo. And in Ottawa, which is where we used to live, they still haven't called about the biopsy. So that's how long she had to wait. And we did that because there have been other family members and other folks from our community that we had heard had gone through such a long wait time to hear back, but someone could have died in that time frame, right? And so yes, in Dubai you do pay, and we were privileged enough to be able to do that, but I would love for you to speak about like the wait times and the process in itself and what we can potentially do to tackle that or address that, because that in itself, even when you do get diagnosed, even when you do get taken seriously, there's a long road ahead. And so I just wanted to raise that. Thank you.
Thank you. I can speak to a program that we have at Women's College Hospital that we've developed through some of the work that we've done, that from the moment we conduct a breast biopsy, we promise a turnaround time of 72 hours. So we partnered with leading labs to provide a turnaround time of biopsy results within 72 hours. And I know there are other leading hospitals out there that are looking at a different form of diagnosis. How do we get the diagnosis quickly? Because earlier diagnosis informed treatment and it informed care. It also decreased that anxiety of waiting. So I know I can speak to what we're doing at Women's, and I'm hopefully that others will hear about what we're doing in terms of turnaround time for biopsy and biopsy results and have those conversations. But I would encourage you to really pick up the phone, make the phone calls, my grandma would say, be a nag, just keep calling and keep asking and asking for the information and asking for the results.
Thank you. Go ahead.
Thank you for having me here today. This is really important for my family. I'll give you some history. So I have a fondness for Women's College Hospital. My father was a fire chief at Women's College. My first job was at Women's College, and my sister studies peace pathology at Women's College. So my journey in the medical world as a patient has been almost reflective. 10 years down the road, I've always found out that when I went for biopsies, for instance, to say that I had irregular cells on my cervix, it ended up that that was not the case, and the conversation about a potential hysterectomy at 18 years old ended up being a myth. No one could find the irregular cells, and that's a consistent theme that has gone on in my life. Most recently, I've taken a position with my doctor that I've asked for my medical files so I can review them. Yep. Now that was a very heavy-handed move on my part, and I recognized, and I had to sit down and strategize, is this the right thing to do as we've grown up together as patient and care practitioner? Is there some other way to navigate other than having the heavy hand? And that was spurred on by a denial of service during COVID for my doctor, and a year of me just being traumatized that, you know, how can someone deny myself and my children service, and having to reconcile that relationship to this date. Is there a website or someone that can help you even read your medical file? Is there a website of maybe practitioners who have had some sort of reprimand, so that when we're looking out for new practitioners or the ones that we're being serviced by, we might see a pattern or a history, and maybe that is not the route we want to go. I've also taken upon myself to be supported by a naturopath and a holistic alternatives in order to have someone validate what I already know to be true and then ask for those medical tests so that my doctor now feels inclined because there's someone else looking at my file. With the Ministry of Health, they don't allow you to have 2 practitioners at a time. I've approached that. Is there anything that happens, for instance, internationally, that is a model we can start to practice that allows someone to have a second look? Because right now there is no second look. If my doctor refers me to a specialist, that is someone that my doctor already has a relationship with. My doctor already can curtail that conversation. I need someone who can look at my medical history with fresh eyes. And this is where I find the roadblock. I feel that I'm quite savvy. I sit on a hospital's board right now as a result of care issues. I'm a very proactive person, but there's a point where it has to stop, and I actually have my own career and can no longer be that second look monitoring my care practitioner.
So, so one thing I can say is that whenever we as physicians we have a college that is our regulatory body, and whenever there are disciplinary actions taken, it is typically posted on the College of Physicians and Surgeons of Ontario website. So if you search for a practitioner's name, that information is available so that you can then decide, is that somebody, you can read why there's disciplinary action and decide, is that somebody that you want to continue with? I mean, I would say in an ideal world, you wouldn't have to get all of your records and review them all yourself to feel that you are getting the best care, right? You want to be able to trust the experts you're working with, whether it's a doctor, lawyer, plumber, electrician, whoever. So I think it brings back that question of the physician-patient relationship and that idea of advocacy. And Dawn, not to put you on the spot, but you've had to advocate for yourself, so just any, I guess, pointers or suggestions you have when it comes to advocacy?
First, I would have to say, know your body, know your history, know your family health history. Do your research so that you go in there informed, and if you're told something, you're not just agreeing with everything the doctor says, that you actually have your own knowledge to lean on, and you can say, hey, you know what, actually no, I understand it to be such and such. So that's my advice. Just do your own research and know your history, know your body.
Thank you all for your engaged questions. Unfortunately, we have run out of time and will provide resources after this event. Please welcome back Jennifer Bernard.
Wow. I saw the little reunion I've been watching. I was supposed to leave, I couldn't leave, I was riveted to the chair. It's so great to hear so many questions. They're hard questions, they're challenging questions. As you can see, this is a necessary event because there's so much to do. We are just at the beginning. But advocacy is complex. If it was easy, it would have already been done. And so we have to be patient, but look at the people that we have supporting us. I want to thank Dr. Aisha Lofters, Elaine Goulbourne, and the amazing Dawn Barker-Pierre for sharing her story. I've heard Dawn's story several times, and it gives me chills. I learn something every day at Women's College Hospital. One of the things I want to stress is we know that everything cannot be done and should not be done at Women's College Hospital. Our hospital is different than any other hospital. We have no beds. I don't know if people know that. We are the hospital without beds. We are the hospital built to keep people out of hospital. We need to change the whole system, not one hospital. Everything that we do, we try to replicate. We offer, we open the doors, we teach. Just exactly what Elaine was saying. If we find a system that works better for Black women, we share it with all the hospitals. If we find a resource that's better for Black women or anyone, we share it with everyone. So I want you to know that is our promise. We are not here just to make Women's College Hospital better. We are here to make everyone better. All right, we're gonna take a little break. There were some snacks on the way in. Now we got some real food for you because we know you're a little bit hungry. We got just a few minutes, we went a little bit over, so grab your plates, find each other, network, exchange emails, go on social media, and corner these wonderful experts that you will not find anywhere else. I'll see you in about 15 minutes. All right, I'll see you soon.